of nice because it makes us more kind of like artists instead of robots. So, and there's 3 million people in the world who are really good at doing a really good SMFA exam or FMS test. There's 100 people in the world who are really good at DNS. So like you get my point. Like we want to strive to be better at this part of it because it's a little bit more difficult, it's a little bit more qualitative, and it's subjective, and it makes you irreplaceable. If 3 million people know how to do what you do, you're very replaceable. If you're good at this, then it makes it hard to fire you. All right, let's start in a 90-90 position now. Whoever wants it. Show, you feeling it again?
Sure.
You want to volunteer? God, this pedal's the ultimate tease. I've hit it like 3 times. Okay, so the first part of the intra-abdominal pressure test is whether or not they're able to maintain position. So if I put her in a 90-90 position, so it's going to get confusing. You'll hear different teachers describe this position different ways. 90-90 and 3-month model are basically the same, all the same. So I need to keep her rib cage down. Really good job. And then if we look at the babies who are developing physiologically at 3 months, you'll never see space here. So you'll see a lot of our patients who are exercising this position, they'll immediately want to go, they're basically training in this open scissored position from this. In fact, I mean, if you go to a local gym, very rarely do you see this right. And what ends up happening then, this becomes a lot of work on the rectus femoris and our hip flexor. So when we get to the exercise portion, I'll show you how we cue this. But for now, for the sake of the test, we hold the legs in this position, hold the rib cage down, and then we simply ask them, when I remove my hands, if they're able to maintain this position. Okay, and then like some people who have like a pretty strong kyphosis will always want to be sure that we've supported the neck well. And then I'll show you here in a second how we can use this position to exercise everything. So once we have this right, I can train our deep neck flexors, we can train arm leg movement against this intra-abdominal pressure. It's just like unlimited just from this position, but we got to get this part right first. Now, in keeping with our compass example, if this was a half circle, I want to see her be able to generate this outward force all the way through here. So what intra-abdominal pressure is it's the ability to do this, expand out, instead of that, which is a brace. There's a huge difference. If I do a brace, I can no longer throw a baseball. If I have good intra-abdominal pressure, I still stabilize my spine as I can relax, explode, and be explosive. Like if I'm a batter in baseball here, I have intra-abdominal pressure constantly here, and relaxation's so important. I'm sorry. If it was perfect, it would be no problem for me. If I was here, you'll never see a Major League Baseball pitcher sit here with the bat still, do you? What do they do? Even if you'll see this. Why? Relaxation. This allows them to be able to relax. Golf, the waggle. No good golfer starts from zero and just starts their swing. They're all gonna like do something to kind of like prime the system, get everything right, and then boom, they start. That is all in an attempt to be able to relax their body. If you want to be good at adjusting, for PTs and chiros in a room, you'll have yourself so relaxed. Like if we're teaching an adjusting seminar, I actually have the Core 360 belt on all the chiropractors or PTs. And they learn how to create pressure and how to be quick with thrusting. So it applies to everything. Okay, so imagine this is a perfect circle. So let's talk a little bit about diagnoses now. So people who have hip problems, let's say sports hernias, inguinal hernias, femoral hernias, labral tears, any kind of groin injury, they typically they always lack the ability to generate pressure here. I don't want to dive too deep into it, but femoral acetabular impingement is a little bit of a, that is an exception. So there's 3 ways to get that. You can either have poor developmental kinesiology, everything we talked about this morning. You can have, you picked the wrong parents, the way your genes came together with your parents. In certain parts of the world, they have, different structures of the hip. And then the third way, so the expert in the world right now is a guy named Philippon at Hawkins Stedman Clinic at Vail. His main guy, one of his main guys, is in St. Louis, who I work with, Dr. King. So I've talked to him quite a bit, and the other guy's in Nashville. Who's from Nashville? Thomas Bird. So if you ever have a hip case, it's going to Thomas Bird. And so anyways, I got to talk to both of those guys, and they believe this influx of femoral acetabular impingement is because of early rotational sports. So it's just basically Wolff's Law. So if you're banging your femur up against your pelvis, you lay down bone there so we can have either the cam or the pincer. But now here's the part that matters. How do you know whether or not they need surgery? Because the severity of the MRI does not matter. That's the one thing we're learning, just like the labrum of the shoulder. So we can't just say, oh, you got a nasty looking arthrogram, we need to do surgery. It's actually your trial of care that should determine the next step. Now, what's hard to find is it's hard to find people who you would trust to give like an amazing trial of care, and then you go 4 weeks and you're like, yeah, it still sucks and we haven't changed this, I think you should have surgery. Or this is the other test that I like. So people with femoral acetabular impingement from a physical exam test, they will get pinched here and they'll get pinched with internal rotation. If they get pain with this and you're able to take that pain away with the treatment session, meaning you have a treatment session, you come back to those tests and they're better, their prognosis is pretty good. If you come back and it's the same, you're still going to run them out on trial of care, minimum 3 weeks. But the prognosis at that point, I think, goes down. That's been my experience. And I've gotten burned a couple times on them. So, yeah, like you could have the most tiny labral tear, but it's in the perfect spot. It keeps driving them nuts, and they end up having surgery. And you'll have the next person who's got a massive labral tear, and they're able to do great, So you don't know till you try. All right, so anyways, those are kind of the conditions that you see with this when people, they'll have like this sucked in right here. So when people have hip problems, one of the main things they need to learn from the beginning is how to stabilize their hip joint against the pressure here. Yes, way to be a stud. Perfect.
What about SI problems? Will they refer to the same spot on the front?
Yeah, you will see it. It's not as direct as a correlation. SI joint's interesting. So in low back pain, what % of low back patients do you think have SI joint as their pain generator? If you had to say.
The generator?
As the pain generator.
Minimal.
Yeah, that's right.
What
So
do you say? Minimal.
Minimal. It's like, they say it's like 7%. I think at times that might even be high. That doesn't mean that it's good to have stiff SI joints. Like if it's stiff, then we can mobilize them or we can manipulate them. But like if I ask a room full of chiropractors at a state association, 1,000 people, they'll say, what do you think they'll say? 70%. Yeah, that's the number. Literally no matter what state I'm in, 70% is what they'll say. So SI joint pain as the pain generator is probably a little bit overstated. Which, sorry about the tangent, just kind of felt like talking about the SI joint for a second there. But yeah, it's but no, you will see it. It's not as direct as a correlation as we see with some of the stuff I just talked about, though. Yeah, remind me too. There's a couple DNS positions that are amazing for when we do need SI joint influence. Okay, so so from this position here, besides removing our hands and seeing if they're able to maintain this position, I want to be able to put my hand here on show, look away, and not know whether she's breathing in or out. What does that tell me? It tells me that she's able to modulate intra-abdominal pressure independent of what? Respiration. Remember, if we're going to carry 135 pounds on a 100-yard walk, if we lose stabilization every time we let our air out, our spine's going to buckle. We're done. So in postpartum women, vaginal birth, you will find like they're unable to separate this. So this would be a great like starting place for those patients there. But again, you got to be sure before we start training this, which right now we're only assessing, that we have them in the right position to start with. Otherwise, we basically just start this posterior compression strategy from their back. So now go anterior pelvic tilt, lift this up. So then now she's going to overload hip flexors, rectus femoris, psoas, and then don't let me move you.
That's good.
And now put this down. Now give me good pressure here. Move my finger. More. Now let me move you. Solid as a rock. So that's also like a good as far as like buy-in for the patient. A lot of times I'll like let them feel on a muscle test what it feels like. This is not a hip flexor muscle test, by the way. What is this? This is a test to assess hip flexor against intra-abdominal pressure. That's where muscle testing gets a little bit, it's not bad as long as you know what it is you're assessing. You're always assessing that muscle against whatever it's needing to stabilize. Sweet. Okay, what'd I miss? Okay, so I just want to do it from this position, and then we'll show you a seated version of it also.